firstly, really want to just express how grateful I am to Action for ME for the support, because without that, we would not have been able to carry out the sleep assessment I'm doing at the moment, which is the most detailed one ever conducted in this population. So thank you for that. And I'll talk about that in a bit more detail towards the end. So a brief background of why sleep is so important in CFS and why I chose to carry it out as part of my PhD. Most patients report sleep disturbance as part of the condition at some point throughout their illness. As well as that, disturbed sleep itself actually exacerbates existing symptoms. So the fatigue, myalgias, and the poor concentration are all exacerbated if the sleep is disturbed. Furthermore, the sleep patterns and severity of the sleep disturbance differ between patients, but also within the same patients at different points throughout the course of the illness. And the sleep studies that have been carried out already, in terms of polysomnography studies, that's the gold standard for sleep assessment, there's only been 30 done overall, and of those that have been carried out, only 13 actually report sufficient data to be able to make any clear judgments about what's going on in patients' sleep. So, and there's no consistent pattern between them either, so it's quite clear we need to perform some good studies in this area. So I'll take you through the research that we've been carrying out throughout the past 2.5 years, and I'll touch upon what we've found through these. We've done some self-reported sleep studies based on patient sleep diaries. Then we've moved on to objective measures of sleep. So a big study, we looked at 343 single-night PSG recordings from a fatigue clinic in Holland. And then moving on to the qualitative study I carried out with patients last year, and the detailed sleep assessment I'm doing at the moment. So from the sleep diary study, looking at self-reported sleep in patients, our aim for this one was to examine self-reported sleep in patients and determine whether sleep quality and daytime napping in fact predicted the fatigue, sleepiness and cognitive functioning. So patients carried out for 14 days a sleep diary, and they also carried out a range of symptom assessment tools for fatigue, sleepiness, cognitive functioning and mood. And having analysed this data, we found huge variability in terms of the sleep characteristics that were coming out of the diaries. Most patients were also napping during the day, and of those that were napping, nearly 88% were napping in the afternoon period, which is in the sleep world considered quite detrimental for the nighttime sleep. It affects the propensity to need to sleep at night. So we found that daytime napping, particularly in the afternoon period, had a negative effect on patients' daytime cognitive functioning and also the levels of sleepiness they're experiencing. Also, we found that a shorter time since diagnosis and a longer wake time in the night negatively impacted on the fatigue. And this we found quite interesting because it would suggest to us that the longer somebody's being diagnosed for, the less fatigued they're becoming. So there's kind of an adjustment effect going on, we might expect. More objective sleep data we've had access to comes from the fatigue clinic in Holland, and it's the largest data set by far in terms of sleep studies with polysomnography recordings. Our aim was to identify whether there are in fact sleep-specific phenotypes in CFS, but also to explore the objective characteristics that could well differentiate these phenotypes, whilst also being quite mindful to how this might be applied to routine clinical practice in terms of treatments for patients. So basically this is just showing how we broke down the data set. We started off with 343 patients. Immediately on analysis, 30% had to be excluded on the basis of demonstrating characteristics of having prior sleep disorder. So 101 had suspected sleep apnea, 17 suspected periodic leg movement disorder. So of the remaining 239 patients, There's the sleep characteristics at the bottom. Highly variable characteristics again. Although it does demonstrate that there are objective sleep difficulties in the sample, I'll just highlight the WASO, the wake after sleep onset there, is almost double of what you would consider normal. A cut-off would be about 30 minutes or more wake time in the night, and these patients are demonstrating nearly 60 minutes. So that's just an idea of the difficulties that are showing in this sample. But moving on to trying to group sample into phenotypes, we performed hierarchical cluster analysis and decided at the 6th iteration this would be the point of saturation, because it was the point at which there was the highest reduction in the number of groupings in the sample, but we're also able to maintain 5% minimum of the sample size in each of the 4 groups. And this is how we stratified the groups. So if we look at groups 1 and 4 that came out of the analysis, these are showing characteristics that look like insomnia type disorders. Okay. Patient group 1 showed problems getting off to sleep, but when they were asleep there were a few awakenings in the night, and the sleep was quite of normal quality, so that kind of reflects sleep onset insomnia. And group 4 demonstrated short sleep duration, no difficulties getting off to sleep, but lots of awakenings for significant periods of time, and this looks a little bit like sleep maintenance insomnia. Group 2 showed no difficulties in getting off to sleep and few awakenings, but feelings and evidence of a restless night's sleep, so the waking feeling unrefreshed. So normal sleep, but very unrefreshing, and this might be due to sensory gain or pain-related problems. Group 3 had sleep characteristics that were quite reflective of hypersomnolence kind of sleep disorders, and this group showed characteristics such as no difficulties getting off to sleep, few awakenings, but feeling unrefreshed on waking despite significant amount of time in bed asleep at night. And you can see from the pie chart there, groups 2 and 3 formed the largest proportion of the sample. Then last year, utilising funding from Action for Me, I began my novel studies, and I started with qualitative interviews with patients about sleep, because in the literature there is a lack of in-depth interview studies out there based on sleep specifically. I carried out 11 qualitative interviews. This was the point at we reached saturation with the analysis, and I focused on sleep-specific experiences. And this just kind of makes it a little bit more easier to see from the transcripts. What came out of them was a whole host of different kinds of sleep problems from patient to patient. But for most patients, 10 out of 11 patients said that this disturbed sleep changed across the illness trajectory. Okay. And there's 3 key themes that came out of this study. These were the sleep pattern variability. So across the time course, within each patient, sleep disturbances were very changeable, but also very unpredictable and inconsistent. Sleep disturbances had a massive effect on the daytime functioning as well, so they served to maintain or exacerbate the symptoms they were already having. And the third theme that came out was all patients were having to attempt to cope at managing their illness. And I found that most patients had a good grasp of general sleep hygiene, what you would get from your GP if you go to your GP for advice about sleep. So they're all really utilising that already, which kind of shows how we need to go deeper into the sleep and treat it more effectively, because they're already doing the basic sleep hygiene stuff. So this is what I've almost finished carrying out at the moment, the detailed sleep assessment. I'm on my final patient in a couple of weeks, and I'll talk you through what we're doing for this 3-day intervention study. So Inclusion for this is 20 CFS patients, 20 normal sleepers aged 30 to 60 years. We're excluding on the basis of sleep medication, circadian abnormalities and apnea and PLMS. So patients, before completing the sleep assessment, have to undergo baseline measures. So we give them a 2-week sleep diary, wrist actigraphy and a whole host of questionnaires. We then go on to perform the sleep assessment. So I go out to patients' homes for 3 nights and we carry out polysomnography, standard 10-20 hookup, record the sleep. They also carry out sleep diary and wrist actigraphy again. And during the day we also take saliva samples at 7 time points throughout the day to get a measure of the cortisol. We'll be looking at cortisol awakening response, but also the diurnal profile throughout each of the 3 days. And this is just the general polysomnography and how that looks. So we'll be using a range of sensors and recording devices. This includes EEG, EMG, heart rate, abdominal respiratory bands, pulsometry, ActiWatch, leg EMGs for restless legs. And this is how the data looks when I upload it the following morning. And just to give you an example, at the top there, that's a period of REM sleep, so you can get an idea of how long that period is lasting for in patients. And obviously that's the raw data. We'll be sending this all off at the end to analyse and be able to kind of determine what's going on in patients' sleep. So the main outcome measures for this study are looking at continuity measures, so timing and duration of sleep, number of awakenings, length of awakenings and sleep efficiencies, but also the architectural aspects of patients' sleep. So we're interested in how much time patients spend in each sleep stage, the transitions between sleep stages, and how long it takes patients to get into each of the stages as well, which is quite important in terms of showing us about the quality of the sleep and things like that. So we can compare patient sleep patterns with normal sleepers. We can also compare the cortisol profiles, because we're taking the cortisol. But the main aspect of this study is to get an idea of how patients tolerate the protocol, because it's quite a taxing study. It's 3 nights and there's a lot of equipment there. But I'm finding that patients, they're finding it okay, and because I'm going out to the homes, it's not too demanding on them. They did say that they wouldn't come into a lab, so that's good to bear in mind for the future. So what I can conclude from all the data I've just discussed is that there are different types of sleep problems in CFS. These vary between patients, but also within each individual patient at different times throughout their illness. The PSG study shows how there are different sleep phenotypes in this population as well, and clinicians should be mindful of these phenotypes when tailoring sleep-based interventions and treatments for patients. It also highlights the need to routinely screen for primary sleep disorders in patients presenting with CFS, as 30% of the sample were excluded initially on the objective study we did. So by targeting disturbed sleep and napping during treatment, we may also improve daytime fatigue and cognitive functioning in this population. That is stemmed from the diary study we did. So this is where we plan to go next. The sleep assessment study is working quite well, so that pilot will help us move forward and develop a larger study with patients to look at the sleep in more detail. The next study we plan on doing is developing a sleep management intervention over at the Crest Clinic, and this will be tailoring the treatments to the phenotypes we identified in the objective study. But ultimately, our aims in terms of sleep in CFS are to establish a gold standard for sleep assessments in this population, triangulate in as much methods as we can in the time we've got, but ultimately improving treatments for patients. That's the main goal. And just thank you to everybody who's helped that research happen. Thank you. Any questions?